A very good afternoon to everyone. I extend a very warm welcome to you for this very important session. It addresses an issue that concerns each one of us here today, whether we are a nursing professional or a faculty member or a student or a resident or a public health person. We saw in the pandemic the severe social and economic crisis that health problems can cause. And so today, we turn a little bit away from the highly specialized clinical hepatology focus that usually this room witnesses, and we delve into the world of public health and health systems research, an area that all of us have a role to play in. And it became clear in the pandemic how important this area is. It's also of particular relevance at this moment because ILBS has had a key role to play in the implementation of the national program for non-alcoholic fatty liver disease, for which we are in regular correspondence with the ministry. And for this very special talk, we are very privileged to have with us our esteemed guest speaker, who's an extraordinary visionary in the field of health systems research, Professor Jeffrey Lazarus, and he's a leading expert in the field. But before I formally introduce you to him, it is my pleasure and honor to welcome our esteemed chair for the session, which is Professor Dheeraj Shah, sir. Dr. Dheeraj Shah is currently serving as the Director of National Institute of Health and Family Welfare, an autonomous organization working as an apex technical institute and a think tank for the promotion of health and family welfare programs in the Government of India. He is on loan the Director Professor in the Department of Pediatrics, UCMS Delhi. He has previously served as the Editor-in-Chief of Indian Pediatrics. He's been awarded numerous very prestigious fellowships, such as the Visiting Fellowship by Royal College of Pediatrics in Child Health, London, Fellowships of National Academy of Medical Sciences, and Indian Academy of Pediatrics. He's an avid researcher, and he's widely published with more than 100 research articles in over 50 chapters in various books. He's also a very talented teacher. We've had the pleasure of attending his talk in one of our previous workshops in ILBS, and he's an extraordinary teacher as well. Sir, I welcome you here. We are privileged to have your invaluable insights and guidance for this session, and I welcome you on the dais, sir. It is now my pleasure to introduce our esteemed speaker, Professor Jeffrey Lazarus. Professor Lazarus is the head of Health Systems Research Group at ISGlobal and an associate professor at the University of Barcelona, as well as a full professor at the Kani Graduate School of Public Health and Health Policy. His decade-long career in health systems, HIV and viral hepatitis at WHO was followed by 3 years at the Global Fund for Fighting AIDS, Tuberculosis and Malaria. He's an author of more than 350 publications and is principal investigator of multiple global consensus statements. He is the past vice chair of the EASL International Liver Foundation. In 2017, he joined the Lancet GastroHep Commission on Viral Hepatitis, and in 2018 became a working group chair of the EASL Lancet European Liver Commission. He is the lead of Nature COVID Consensus and the co-author of the Lancet COVID-19 Commission, and is on the editorial board of HIV Medicine, International Journal of Drug Policy, and Journal of Hepatology. Throughout his career, Dr. Lazarus has been at the forefront of driving evidence-based health interventions, translating research into practice, and optimizing health systems for better patient outcomes. Today, we have the distinct privilege of directly hearing from Dr. Lazarus as he shares his latest findings and insights on the Barcelona Institute of Global Health's work on fatty liver disease, viral hepatitis, and COVID-19. I encourage all of you to actively engage with Dr. Lazarus during the interactive session that follows the talk. Your questions and discussions will undoubtedly enrich our understanding. We are grateful to have you here today, Professor Lazarus, and please join me in extending a warm welcome to him for this very important session.
Thank you very much for that warm introduction. Thank you, Dr. Serene, for the invitation to come to the ILBS today. I arrived in Delhi after midnight last night, and I'm leaving tomorrow. So I really came in the spirit of collaboration to tell you about the work we're doing in Spain at the Barcelona Institute for Global Health, and our work particularly focusing on liver health, both fatty liver disease and viral hepatitis. So as such, it will be less of an academic lecture and more of a sharing of the work we're doing with the idea that perhaps we can further the collaboration we already have. I'll be presenting some studies and some global collaborations that Dr. Serene and the ILBS have been a part of, and hopefully we can expand that. I was very well received earlier today, and we had a nice discussion about the work going on in the field in community medicine, and it reminded me of when I was first in India over 20 years ago to study community medicine at the Christian Medical College in Vellore for a couple of months. Back then, the university I was working at in Denmark had a close collaboration with the CMC. I haven't been back in over 11 years. The last time I was here, I was at a WHO regional meeting talking about the importance of addressing hepatitis C, even if the medicines weren't so effective. Look at where we are now. We can start to talk about the elimination of hepatitis C as a public health threat. And as mentioned, I spent 11 years from 1998 to 2009 at WHO. And since then, apart from working at the Global Fund, have primarily had an academic career, although I would call it more of an academic activist or an academic advocacy career, working very much in the realm of policy and trying to change systems, not just addressing change one individual after the other. So I lead the health systems research team at Barcelona Institute for Global Health, what we call ISGlobal. This is an institute with over 500 staff now based in Barcelona, bringing together a vast array of different research groups. We're funded by both the government, foundations, academic institutes, and we're linked to 2 hospitals. If you're working in the field of hepatology, you probably know the Hospital Clinic in Barcelona, where I work, as well as the Hospital del Mar on the other side of the city and linked to both universities there where we have our academic affiliations. One of the goals of ISGlobal is not just research, but translating that research into action and into policies. So we say we are founded on our educational roots, but we also work on research as well as knowledge translation. And you have some of the numbers at the bottom, but it is a group that's very productive. There's over 30 different research groups, and we're also a WHO collaborating center, but that's on malaria, an issue I don't work on really at all. So what my team tries to do is address some of the most pressing public health risks challenging global health systems. So earlier on, that started with HIV, and as I'll explain, it started to transform in, I think, a very organic way into other areas. Originally, I'm from New York. I was living in New York City in the 1980s, watching people go to centers to find a place to die in the absence of antiretroviral therapy, and that's what really motivated me to get into the field of medicine, but also into the field of community medicine, watching entire communities in a very well-developed, high-resourced setting have no alternative other than to find where they could end their last days. Our group is multidisciplinary, as I'll explain in a moment. There are actually very few clinicians in my group, which isn't a problem because we're at a hospital where almost everyone else is a clinician, so we bring something different to the field. And our overall goal is really to reduce the human and economic burden of disease on these major unmitigated challenges while increasing quality of life, both individually and addressing health equity more broadly. This is the team. I won't go through all of them, but they're from Argentina and Colombia and Italy and the UK, Israel and the US. We have a lawyer on the team, which turned out to be a former lawyer, I should say, incredibly useful during the COVID pandemic when we were talking about how to implement control measures, what would be legal, what would be illegal, how do we monitor and reform social media platforms where disinformation was spreading. That's when he joined the team. But we also have a health economist, 2 health economists, ID doctors, an anthropologist, and 2 clinical dietitians. This is the core team. We have a larger team that includes our community health agents, our nurses working in the field. We run clinics twice a week, always outside the hospital. The further away from the hospital, the better, because it often means we're meeting people who weren't going to make it to the hospital. And we started there addressing hepatitis B, and as I'll show in a moment, the rapid diagnostic tests we use. We expanded that to hepatitis C, excuse me, and later we combined it with COVID-19 vaccination and infectious disease testing at the same time, trying to integrate care, something that makes good sense. It sounds very simple. It's often very complicated. And our most recent study trying to integrate care, which was a cluster randomized controlled trial, was just accepted into the Lancet for publication, showing that when you do it right, when you have large numbers and you take complex issues and have strong results, you can reach one of the top medical journals in the field. So these are the 4 main areas of work. So fatty liver disease, we're looking at the global public health agenda. We're trying to set research and action priorities, looking at countries, if countries have the right policies in place. We have a large collaboration called LiverAIM, which will be developing a diagnostics platform over the next 6 years. We have a project called CARPA, where we're bringing FibroScans into primary care, and I understand, I've seen your FibroScans here, but I understand you also have portable FibroScans in Jaipur and maybe in other areas, and how important it is to be able to do transient elastography like in the van you have outside in the community, because not everyone can always make it to the hospital. The NASH PI project with Dr. Manuel Romero Garcia brings the FibroScan and other tests into diabetes clinics, and then we're also a part of some of the large conferences, which I hope you'll join us in, the EASL-NAFLD conference, which I'll be chairing this year in Prague, and INC-BCN, which is Innovations in NAFLD Care, that I direct with Dr. Jorn Schattenberg. In terms of viral hepatitis, we launched the idea of microelimination. We said if countries aren't willing necessarily early on in the pandemic or the epidemic to address the elimination of hepatitis C with the new medicines, we could think about particular settings. It could be a state, it could be a city, more complicated. It could be an individual hospital or a particular population. Anyone with HIV on antiretroviral therapy should be tested for hepatitis C. If positive, they should be cured. Anyone with hemophilia, with common co-infection. People on dialysis and nephrology. So department by department, where we expect a higher prevalence, we can start to micro-eliminate hepatitis C and ultimately lead to the full elimination of hepatitis C in the community. And then we have some projects listed here that I'll introduce very briefly afterwards, just to give you an idea of the kind of work we do. Maybe some of it you're doing, maybe some of it's inspiring for you to do, maybe some of it's not relevant at all, and maybe some of it's something we can do together, which we can discuss during the question and answer. And finally, around COVID-19, when our projects were stopped and we had travel or movement restrictions and weren't able to go into the field, and we started to see the same mistakes being created with COVID-19, but on a much bigger scale with, I think, much more devastating potential consequences, we turned the entire team to work very quickly on COVID-19 with very little funding, which has been quite problematic because we had our funding for our regular projects, but we weren't able to implement them. We started working on COVID-19. We ran the first global vaccine hesitancy study that was in 19 countries. We expanded it to 23 countries. We've been running it each year. Sometimes science can be very simple. We asked 2 questions about vaccine hesitancy, and it became the most cited publication of 2020 in Nature Medicine. We later expanded it to ask many, many, many questions. It got even less attention, but as scientists, we wanted to know not just if there was vaccine hesitancy, but why people were hesitant. What were the issues around trust in science and what were the differences among different demographics. And finally, we decided, in the absence of WHO action on the matter, we would create a global strategy. And we've collaborated with many of you in India, but experts, 386 experts from 112 countries, to create a large global strategy, ultimately published in Nature, about what needs to be done to end the pandemic. And even if I enjoyed my years at WHO and have great respect for this specialized agency of the United Nations, I feel they failed us very much in bringing together a comprehensive strategy that also had input from experts and populations all over the world. I won't spend much time on HIV/AIDS, given the time limits here. I also want you to be able to get out again, and I thank you again for taking the time from your busy schedule to join me, but I did just attend the AIDS conference in Brisbane, Australia, and it was from there that I flew in yesterday. So, back in 2019, I was thinking that, fatty liver disease really wasn't being addressed as a public health issue. So we brought together a group of experts and snowballed it to over 200 people from different disciplines, a multidisciplinary group from almost 100 countries, to gain consensus on fatty liver disease as a public health issue, what we would later start to call even a public health threat. So we have this consensus statement. You see our cover here. You see maybe in the back the clouds and the formations in the sand that look like livers. I enjoyed so much the art exhibit you have in your reception at the main entryway. This was our contribution to liver art on the cover of Nature Review's GastroHep, but importantly, it drew a lot of attention from liver specialists to the public health field. And I understand why gastroenterologists, hepatologists, and others aren't addressing the public health aspects, but if we are going to really address a condition that is estimated to affect more than 1 in 3 adults around the world, we are going to have to take a public health and policy approach. This is what the recommendations ultimately look like, grouped into these areas around leadership, and India, I believe, is the only, or at least the first country to have a national strategy on NAFLD, understanding the human and economic burden. The human burden we know from the recent prevalence studies, including the UNASI study in February in hepatology, but the economic burden needs to be studied very carefully in each country, and that's one of the issues that you can also use to advocate to your policymakers, not addressing liver disease in isolation, but looking at the bidirectional relationship with diabetes, the underlying causes of liver disease, and what will often be the leading cause of death for people with liver disease being cardiovascular disease. We need to raise awareness. We need to raise awareness about the public health aspects among liver specialists, but then we need to turn to our clinical colleagues, policy and decision makers, and ultimately the population at large about this. There are treatments in the pipeline, but in the absence of specific pharmacological treatments, there is still a lot we can do around increasing physical activity and changing diets. That is complicated, but so is lifelong adherence to treatment, so we need to be addressing both, I think, in tandem, and right now our only option for our patients are the lifestyle changes, so we need to think, how can we best do that? And I think that's about expanding the community of practice, collaborating with endocrinologists, primary care specialists, community agents, and others to make those lifestyle changes. We need to be looking at the policies and strategies that need to be in place and make sure that liver disease, and specifically fatty liver disease, is a part of non-communicable disease, is a part of an NCD strategies, organizations, and agencies. We need to look at how do we engage the community, how do we engage different patient groups, liver groups, diabetes groups, liver cancer groups, and so on. And finally, defining and implementing models of care. I'll show you in a moment, but when we reviewed the existing models of care, there are very few published successful models of care, and it's important that models of care be multidisciplinary and lead to the best outcomes possible by using the fewest resources possible, as I'll explain. We carried out, after that global consensus, a policy review India came out scoring best, and that led many people to ask, well, why India? And that was a great opportunity for India to showcase what you've done with the strategy and the attention you've been able to give this. So I think, at least in the areas where I'm working, we learned a lot from the India example, and so saw how poorly many well-resourced countries are doing in terms of addressing fatty liver disease. In fact, around the world, 1/3 of the 102 countries we studied scored a 0, and even if India did best, all countries were found to be failing when we put the score from 0 to 100. So, no lack of ambition here. We looked at the policies that are in place. We created a global consensus on the issue, and then we said, well, if countries are committed to the Sustainable Development Goals, to the SDGs, could we link that up with fatty liver disease? So we created a fatty liver disease SDG score for the 195 countries and territories from where we had data. If you're familiar with the global burden of disease, we worked closely with the liver team there and created this score. I won't go into the methodological details. You can read it in hepatology, but we looked at we had a Delphi to agree on the relevant indicators for just 60 countries. We had one we thought that was incredibly important, which was called Urban Green Spaces, or UGS. If we tell people to increase their physical activity, but they have no place to go running and exercising, that's going to be very difficult. As one collaborator mentioned, you may have the green spaces, but they may be very dangerous places to be alone and go exercise. So we do realize it's all relative, but it would be good to have more places to have physical activity if that's one of the primary recommendations we're going to recommend to people. And thinking about the inequities and the disparities among the populations we're seeing with fatty liver disease, we know that everyone's not going to have the opportunity to exercise at home, to join a fitness center, so on and so forth. And what you see here is that in general, the higher income countries that are doing better on the SDGs are doing better on fatty liver disease, but that's not always the case. And when we look carefully, we can start to identify where countries can do a better job. So, Dr. Sarin, you joined us in 2020 online. Here's the 2022 photo when 50 of us gathered at Wilton Park, which is a think tank similar to Chatham House in the United Kingdom. And we founded the Healthy Livers, Healthy Lives collaboration of AASLD, Apostle, ALE, and EASL, the large liver organizations, collaborating around, I think, the issue we all agree on, the importance of raising awareness about fatty liver disease, again, among our clinical colleagues, among policymakers, and among the general population. And we agreed that we would develop a roadmap, a set of research priorities and action priorities, filling the gap that WHO has created because the World Health Organization is not addressing this at all. I often jokingly say that when you look up a NCD technical guidance from WHO or any of their strategies or action plans, you don't find an NAFLD, you don't find a MAFLD, you don't find a MASLD, you only find the word liver when it's a part of the word deliver, and it's to deliver on cancer care and it's to deliver on diabetes care, which is of course something we all agree on, but that's the only mention of liver, as if fatty liver disease couldn't even be mentioned in a footnote of WHO guidance on non-communicable diseases. We are trying to address this, as I'll show, at the global level, but I think here at the regional level, you can also work with your India office, your Southeast Asia office, and see what kinds of changes you can make in the guidance and strategies there. When I was here 11 years ago, it was because we had an opportunity to speak at the WHO regional meeting. We were given 1 minute and a half to talk about the importance of hepatitis C, so we chose our words very carefully, but this is how things start. And again, look at where we are with hepatitis C, and I realized that the advent of DAAs did propel us forward very quickly. After that Wilton Park meeting, we started a global consensus that would ultimately reach almost 300 people from 94 countries, looking at the research priorities for the field, again in these same 6 priority areas, but we wanted to see what the priorities should be in terms of research, and we would rank them. So what would be the most important issues? I obviously won't go through them in detail. The article is freely available in the Journal of Hepatology, but we listed here just the top priorities in each area. The bolded priorities are those that had unanimous agreement, but overall there was a high level of agreement among each of these 6 areas. It doesn't mean you have to do this research, but it starts to give us an idea of what's needed in the field, and it's a useful justification for your funding proposals or for your own research for why you think it's important. Well, this is what the global consensus said. I mentioned Healthy Livers, Healthy Lives, the event we held just over a month ago, and Dr. Serene was in attendance, as well as leaders from many of the leading organizations. We put forward a vision to end fatty liver diseases as a global public health threat and to mobilize action for fatty liver disease. We engaged with the World Health Organization. The head of their non-communicable disease program was there. This was the first time we were able to speak directly in this way to WHO experts. For any of you who think you can't say what you need to say quickly, we were all each given 3 minutes to make our talks, and we had about 30 different speakers during that hour and a half. We launched this call to action for professional societies, clinicians, patients, and others. You see on the top right the Minister of Health of Brazil signing this, the Minister, that's the Minister of Health of Egypt. We had the Minister of Health of Brazil. We had experts from around the world signing on to this call to action. Each year we meet in Barcelona very briefly for a day and a half and talk about innovations in the field. It would be great if we could establish a collaboration. It'd be great if you would send some of your art, but also send some of your experts to share your experiences at that meeting. Oh. So just before I submitted my slides talking to our colleagues, I made a few changes, and I just wanted to share some concrete examples of what we're doing in the field. When we've engaged with patients and engaged with the community, they've always said we want fewer visits. It's okay if you have great services, but we really don't want to come to the hospital. How can we do this in the community? So if we're going to have a venous blood draw for hepatitis C, tested for antibodies, even do a second draw. I don't know if you reflex test here, but in many centers around the world, if not most, they don't reflex test, so they need a second blood draw. Then they can do their RNA testing and ultimately give a diagnosis. With a dried blood spot, you can reflex test off the same Whatman card or plasma separation card, if you're familiar with that. But you can also use rapid detection tests. We use them for hepatitis B, for hepatitis C, not just same-day diagnosis, but within a few hours. And if you have gene experts, and I think that's the case, and if they're portable like ours, you can go straight to RNA and in just 1 hour know if you should be treating that person for hepatitis C or not. These are what rapid detection tests look like. I find that many clinicians are not familiar with them, although now we're all familiar with rapid detection tests thanks to the COVID pandemic. Even my little daughter knows how to do an antigen test, but there was a time a few years ago when most people didn't know how to use these, and they're so incredibly simple to be able to test in the field, in this case to see if the person is antibody or HBs surface antigen positive. Then we can also use the Whatman card on the right or the Roche plasma separation card on the left. You peel it back when it's dry. It separates the plasma from the whole blood. So for those of you who work in labs, this means you don't need a whole blood sample. You don't need to centrifuge. You don't need to refrigerate. We store ours in Tupperware with desiccant that we buy online. It can be stored at up to 40 degrees for almost 40 days. So this means that after we test in the field, we can just keep it wherever we want to keep it, in the office, in a drawer, or even at home or in the car, until we have a chance to get back to the lab, because a lot of our testing is done outside of the cities. And if you're familiar with the Gene Expert, you know what this cartridge looks like and how easy it is to put it into this little machine. This is a machine that takes 4 cartridges simultaneously. So in 1 hour, you'll have your RNA results. You might be using it for tuberculosis or HIV viral load. It's a multi-platform tool. It can now also do COVID testing. We have one in a van in Denmark where I run a project, and it goes around to the different centers and does the testing on site with no need to go to a hospital lab, and in some cases no need to see a doctor or a nurse. Even pharmacists in some settings are allowed to do that. During the pandemic, we ultimately were able to launch 2 projects, and I just want to interventions. I'll just tell you very briefly what they are. So this is my team in the field. On the far right, that's inside a mosque. On the far left, it's in a Christian religious ceremony. We work with the Ghanaian and Senegalese communities. We go out into the field and we test 20, 30, 40 people for hepatitis B and hepatitis C. If you look very carefully in the middle photo in the back, you can see the filled in plasma separation card with the red blood drops there. And we're also in charge of hepatitis C elimination on 3 islands of Spain. And here are just some images of the different care pathways we've developed. And again, all of this is done outside of the hospitals, but to engage with the hepatologists, we implemented a telemedicine system. It took a little while. There was some concern. We need to see the patients. We said, what do you need to see them for? You're going to get the results. They said, well, we need to check for fibrosis. And we said, there are ways we can do that before they get to you. We can still start them on treatment because this is about a virus. And then ultimately, they can come to the hospital and get fibroscanned. But we don't need to delay treatment and care before we've genotyped or fibroscanned. And especially with regards to genotyping, it's so not important anymore in many countries where we're using pan-genotypic direct-acting antivirals, or DAAs. We were able to scale up this project across Europe. And again, everything you see there of equipment, we just carry with us in roller bags or knapsacks. And then we work in the community for that day and then leave again. And most of that is done during the weekends, during the religious ceremonies. So between the 2 projects, we've now screened a couple thousand people. Our hepatitis B prevalence is over 10%, and our hepatitis C prevalence is over 11%. So this is in a high-income country of Spain, but in low-income populations. When you go to the right population that needs care, we find a lot of viral hepatitis. When we test in primary care, we won't even find barely 1 in 1,000 people testing positive. And here is the project on the islands. There's Andrea from my team in the middle picture with the white coat on. She's a PhD student, not a medical doctor, but she does all of the counseling and all of the testing and then refers. And here you have the latest numbers. It's now 12% prevalent of 1,400 tested for hepatitis C there. This is a mobile van we collaborate with in Madrid. It goes into the shanty towns, and when they were stopped during the pandemic, for health reasons, a part of the COVID-19 control measures, we suggested that if they went and vaccinated for COVID-19, during those 10, 15, 20 minutes when the patient should be waiting to see if there's an immediate adverse event from the vaccine, we could use it for something. So for anyone who's been vaccinated, what did you do during those 10 or 15 or 20 minutes? And most people say, well, they looked at their phone, they just kind of sat there, maybe they had a health pamphlet to read, but at least across Western Europe, most people just looked at their phone. So we went in and we tested for hepatitis C, for HIV. In the first 100 people we tested, we found 9 RNA positive for hepatitis C. So again, when almost the entire population was vaccinated, those who weren't were those who were co-infected with other infectious diseases, and we were able to change the system a bit and circumvent the control measures. We publish regularly in Nature Reviews GastroHep. These are think pieces. They're targeted towards policymakers, decision makers, hospital administrators. On the right, you see a piece we just led on measuring models of care for fatty liver disease, and earlier sounding the alarm on fatty liver disease. And on the right, the second one down, we've set out 10 steps to eliminate hepatitis C within hospitals. Because when we studied the hospitals of Madrid, the public hospitals of Madrid, we found that none of them had eliminated hepatitis C, and many of them had 1 in 10 people from high-risk populations in the hospital who had not been tested for hepatitis C. So while we need to look in the community for hepatitis C, we also need to look in our own backyards within the hospitals. And so as mentioned earlier, we launched a multinational consensus to end the COVID-19 public health threat with a panel of almost 400 people from around the world addressing the key pressing issues. This got a lot of attention at a time when things were starting to improve in COVID-19, but we still don't have a WHO strategy. We still don't have a pandemic treaty in place. I'll start to wrap up. This is the study on COVID-19 vaccine acceptance on the cover of Nature Medicine a few months ago. Still finding that not only are people hesitant, but there's also a new phenomenon of vaccine fatigue. We need to get vaccinated so many times. You may believe it works and want to get vaccinated, but you're just tired of getting vaccinated. So that's another issue we need to address from a public health perspective to be able to help improve the clinical outcomes. On HIV/AIDS, really our contribution in recent times has been to look beyond viral suppression so that those who are on long-term antiretroviral therapy can have other issues addressed related to their quality of life. First and foremost, multimorbidity, but also self-reported quality of life and the persistent stigma and discrimination affecting that community. Across Europe, we do other work around vulnerable migrants and infectious diseases. And then as mentioned, the Into Africa trial that was just accepted for publication is a cluster randomized controlled trial bringing diabetes and hypertension care into HIV clinics. And the meta trial is an RCT on metformin for people living with HIV who are pre-diabetic, running both in sub-Saharan Africa. And finally, this is the study I mentioned already, the Fatty Liver Disease Sustainable Development Goal collaboration, or SCORE, but we also have a collaboration with the Global Burden of Disease on the Spain study that we lead, looking at the key indicators in Spain in order to inform policy about where interventions should be put in place to improve the population's health and health outcomes. So let me conclude by really just leaving a little bit of what I was brainstorming about areas of collaboration. It would be great to foster more collaboration, also research collaboration. There are real-world studies. We can be looking at models of care. We can be looking at point-of-care studies, the outcomes, the epidemiology. We want to look at liver health more broadly, get beyond just fatty liver disease or just a particular virus, but think about the liver as a whole. You know, how do we do that, and how do we get colleagues from other specializations to address it as well? First and foremost, I think, endocrinology. We're always up for a systematic review. The people on the team are quite experienced in carrying out those reviews and open to other ideas you might have. So let me thank you again for making the time to be here, and again for the opportunity, Dr. Serene and colleagues, to share some of the work I'm involved in at the Barcelona Institute for Global Health. Thank you.